Hey everybody, my name is Michael. I've been on the Discovery unit as an intern for almost a year now, and this is a service learning project that I've put together to hopefully offer you some um, possibly a refresher or new information on suicide risk assessment. I know that getting coffee is usually the job of the intern, but I thought I'd break stereotypes with this and offer you all suicide assessments instead. Um, so I'm going to kind of do a review of 3 suicide assessments and 2 behavioral assessments. First, we have the Columbia Suicide Severity Rating Scale. This is the most widely used suicide assessment that I've found and the most evidence-based. Most of the programs around the country are using this assessment. It's 6 questions. It's been shown to be valid in assessing both adolescents and adults, and it's useful in distinguishing between ideation and behavior, so whether someone's thinking about it or acting. The next assessment is the safety assessment. This is more comprehensive. It involves 5 steps that include identifying risk factors and then identifying protective factors, following that with some suicide assessment around thoughts, plans, behavior, and intent, and then determining risk level and appropriate interventions, and then documenting that risk level and interventions taken. This is an assessment that's sponsored by SAMHSA and derived from data from the APA, so it has a lot of support behind it. And then the third suicide assessment is the CARS assessment. This is also a comprehensive assessment, but it focuses on cultural competence. So I thought that this would be appropriate to share for the Discovery unit in particular, because this is an assessment that includes identifiers of cultural suicide risk factors that aren't really on the other assessments. This assessment has been shown to be more effective in assessing ethnic and sexual minorities, both of which populations are pretty heavily represented on the Discovery unit. And it's a self-report instrument, and it's been shown to be reliable in general populations. And then moving on to the behavioral assessments, the PHQ-9 is one of the most widely used behavioral assessments. It assesses for depression severity. It's been the adolescent modified version is only 9 questions. It's pretty simple. It's based on DSM-5 criteria, and it's been shown to be reliable and valid in measuring for depression severity. And then the M3 checklist is more of a comprehensive assessment that will assess for depression, anxiety, PTSD, and bipolar disorder. This is 1 page, 27 items. It's a self-report checklist that usually takes less than 3 minutes for clients to complete. So that can be an easy way to kind of get a baseline for clients, is using that M3 checklist. The next area of suicide risk assessment that I wanted to cover was what different programs use. And for this, I just Googled best children's hospitals in the country and called the top 5 along with a couple local places, and asked them what they used for formal assessments on intake as well as ongoing suicide assessment in their program. When I called the CRC, they let me know that they used the CSSRS, the Columbia Suicide Scale, and that ongoing assessment is determined by suicide risk. So it can be once or twice a day, depending on risk level. The Seattle Children's Hospital has their emergency department do the formal assessments, and didn't know. And they also told me that they don't have any ongoing suicide screening on their unit, which was surprising. The Boston Children's Hospital uses the CSSRS, and they use safety scaling questions for ongoing assessment. So how is your safety on a scale from 0 to 10, and then follow-up questions of suicide or self-harm or whatever it might be. The Cincinnati Children's Hospital didn't give me a lot of information. The only thing they told me was that they fill out the mental status exam for each patient every day. The Rady Children's Hospital, they use both the CSSRS and the PHQ-9 in order to assess for suicide on intake. And another surprise that they don't have daily suicide screening, but they do fill out the mental status exam every day. The last hospital that I called was the Children's Hospital of Colorado. They use the CSSRS for formal assessment. They also use state scaling questions, and they let me know that their doctors and treatment team both meet with patients every morning. So they have a lot of overlapping care there. And then behavioral assessment is the last area of assessment that I wanted to cover. And I think it's one of the most important areas, especially for the discovery unit, when ongoing assessment is done every day, multiple times a day, whether it's scaling questions or just behavioral observation while on the unit. And Thomas Joyner is one of the lead researchers on suicide. And he came up with acute suicidal affective disturbance to describe some of the perceivable behaviors that can be seen in individuals with a higher risk for suicide. These would include either overarousal or being shut down. Overarousal can include insomnia, it can be nightmares, agitation or restlessness, also irritability. And then being shut down can involve social alienation or self-alienation. Social alienation is the disgust with others, a perception of being a liability on others. And then self-alienation would be a perception of burdensomeness or a disgust in yourself and the person. Thomas Joyner also did some interesting research with blink rate. He believes that blink rate can be a useful tool in determining level of suicide risk. So diminished blink rate is found in people that are doing a task that requires like really high concentration, planning and attention, like a fighter that's getting ready to go into the ring to fight. But it can also be seen in behaviors like being really serious about attempting suicide. So what Joyner hopes is that with blink rate being such an observable behavior, that it can be that diminished blink rate might signal imminent suicidality and be a useful tool in assessing suicide risk. And then for reference, if anybody wants to try to use this, it's 12 to 15 times a minute is the average spontaneous blink rate. Some other interesting information are physiological monitors. One study I found uses the Empatica E4 is the name of it. It's worn like a watch and records several streams of data, including electrodermal activity, heart rate, temperature, and movement. This was just a feasibility study to see if it's even possible to have patients wear the monitors. But in the future, it might be possible to assess suicide risk with physiological monitors. And then other information I found that I thought was interesting was clinician eye gaze duration. This is something that isn't immediately applicable, but interesting information in that the duration of a doctor gazing at a patient was 81 to 90% correct in predicting future suicidal behavior. Whereas that same doctor, when they gave their verbal prediction, was only 22% correct. So it's interesting that this reflects like a doctor's perception of risk without that awareness. So the clinician is not aware, but is unconsciously aware of suicide risk in an individual. And some additional findings that I found in my research is that compliance with suicidal assessments is higher in the middle of the day compared to morning or night. And there were actually 2 studies that showed almost as much variability in suicidal ideation from hour to hour for a single patient as from patient to patient, which was interesting. So just significant variability in suicidal ideation. And another study found that suicidal ideation was associated with average daily affect intensity, but not associated with within-day variability or magnitude of change in affect. So it's saying if someone is experiencing, if someone goes from being sad to happy on a lower scale, they will have less suicidal ideation as compared to someone that is experiencing one emotion all day at a very high level. So it's the intensity of emotion that impacts suicidal ideation more than kind of the range of emotions that are felt. And finally, just to kind of close everything off, a quote from Thomas Joyner letting us know that for ongoing assessment, the single best question to ask about intent is on a 0 to 10 scale, how much do you want to take your life? And then supporting that question with behavioral observations like the ones that I just overviewed. So I hope that some of this information was helpful and useful for you. If you could complete the survey that was included in this email along with the YouTube link. It's only 1 question. So it'll be really short, I promise, and I would appreciate it. And then here are some of my references if anybody is interested in learning more about any of these topics. So thank you.